So I worked in Shaukat Khanum Hospital, Lahore, which is the top picture. It was developed 20 years ago, and it treats patient with cancer, and about 80% of the patients are treated free with the donations. The Shaukat Khanum family is expanding, and we have developed a Shaukat Khanum Peshawar, which is the lower left picture. And we are currently working to develop a Shaukat Khanum in Karachi, which will start working in next couple of years. And this is the modern only. So my presentation outline is I will start with a clinical case, so you can have a taste of adrenocortical cancer. Then I'm going to talk about the treatment, the prognostic factors in adrenocortical cancer. And then I will talk about the experience of management of adrenocortical cancer in our center. So I will start with a 30-year-old lady. She presented with right lumbar region pain for 3 months, increased facial growth, and irregular periods for 5 months, no history of diabetes or hypertension, was not taking any medications. She was normotensive, pulse was normal. Her abdominal examination showed large right-sided abdominal mass. There was no clinical features of Cushing syndrome. Her CBC, UNEs, and LFTs were normal. You can see that on the CT scan, there is a large right suprarenal mass, which is compressing the liver as well as the kidneys. She had a hormone profile which showed she have raised testosterone and DHEA sulfate. She failed to suppress on overnight dexamethasone suppression test. Her other hormone profile was normal. She underwent right en-bloc hemihepatectomy and adrenalectomy. Operative findings was that the right adrenal tumor was densely adherent to the right lobe of the liver. Her histology showed adrenocortical cancer, 26 centimeter. There was no lymphovascular or perineural invasion was seen. Liver margin were free of tumor. Her modified Weiss score was 5. Melan A and inhibin were positive, and calretinin was negative. Her proliferative index, Ki67, was 24%, and mitotic rate was 15 per 50 high power field. So she was T2NOMO, and on NSAT stage, it was stage 2. She had an uneventful recovery after the surgery, went home after a few days. We saw her again in 4 weeks' time. She was doing quite well. She reported that there was the excessive facial hair growth have improved as compared to the past. She previously used to remove them, and that the removing frequency did reduced. Her testosterone, DHEA sulfate, and was normal, and she actually, on overnight dexamethasone suppression test, the cortisol level was normal, and she suppressed normally. So now the next question is, what should be the next step? Either we should go for a surveillance, which means we follow biochemically and radiologically. Either we should start her on mitotane, which is an adrenolytic drug. Either we consider her for cytotoxic treatment, or either we consider her for radiation therapy. Anyone in the audience want to comment? Or? Okay, so what I'm going to do is I'm going to talk about adrenocortical cancer so we can answer this question. So adrenocortical cancer is rare but highly malignant, with incidence of 0.72 per million person per year. Most patients initially present either with abdominal pain or symptoms secondary to the hormone excess. A small percentage is incidentally discovered on imaging, which is done for a different reason. It is characterized by a poor prognosis, with only 16 to 38% of patients surviving for more than 5 years from their diagnosis. Majority of patients have resectable disease at presentation. However, as many as 75 to 85% have a relapse after the radical resection. When we talk about the treatment, it depends upon either it is a suspected localized adrenocortical cancer or either it is an advanced adrenocortical cancer. So for suspected localized adrenocortical cancer, the complete surgical resection is the only potentially curative treatment for adrenocortical cancer. So European Endocrine Society published guidelines, which was published last year, and the recommendations are here. So I put a few recommendations on this topic. So for suspected localized adrenocortical cancer, they suggest that adrenal surgery for suspected or confirmed ACC should be performed only by surgeon experienced in adrenal and oncological surgeries. We recommend complete en bloc resection of all adrenal tumor suspected to be ACC, including the peritumoral/periadrenal retroperitoneal fat. We recommend against the enucleation and partial adrenal resection for suspected adrenocortical cancer. If adjacent organs are suspected to be invaded, we recommend en bloc resection. However, we suggest against the routine resection of the ipsilateral kidney in the absence of right renal invasion. So we talked about that most of the patients initially have resectable disease. However, the relapse is quite common. So the next step is what treatment we can offer. So if we go on adjuvant settings, we have adjuvant mitotain, adjuvant radiotherapy, adjuvant chemotherapy. However, there is no randomized control trial yet regarding the efficacy, regarding the effect of these adjuvant therapies. There are multiple retrospective studies, but there is no randomized control trial yet. There are many in the pipelines, and hopefully we will have answer of this question in a couple of years. So in the retrospective study, the one major study was published in New England Journal in 2007 was use of adjuvant mitotain for adrenocortical cancer. This was a retrospective analysis where 177 patients with ACC were included. These patients had radical surgery at 8 centers in Italy and 47 centers in Germany. Adjuvant mitotain was administered to 47 Italian patients, which was classed as mitotain group, whereas 55 Italian and 75 German patients did not receive adjuvant mitotain after radical surgery, and they were control group 1 and group 2 respectively. So these are the characteristics of this group. And if we look here, although the population are quite similar, the only main difference was that the German group, they were slightly older. If you look at the tumor stage, the German group have more patients in stage 1 and 2 as compared to the Italian. And if you look at the Y-score, the median Y-score for the Italian group was 6, whereas for German group it was 5. The recurrence-free survival, which is the time interval from the time of the surgery to either the recurrence or for those patients who do not have recurrence, is time till the last follow-up, was significantly prolonged in the mitotain group. So the median recurrence-free survival was 42 months in the mitotain group as compared to 12 months in control group 1, which was the Italian group, and 25 months in group 2. If you look at death from ACC, so mitotain group had 25 deaths, whereas control 1 and 2 have 55 and 41. If we look at the overall survival in months, mitotain group median survival was 110 months, whereas group 1 and 2 have 52 and 67. This is a meta-analysis where it's showing it's showing multiple studies regarding the mitotain use, and you can see In the top one, the diamond, which is actually on the treatment side. So in terms of recurrence, the mitotane does help. There is also lower down, it's regarding the radiotherapy, which we will discuss in a minute, but you can see here the diamond is toward the treatment as well. When we look at the same for the mortality, definitely there is a benefit of mitotane in terms of improving the mortality, whereas for radiotherapy, that is not the case. So we know that mitotane improve the recurrence-free survival, improve the overall survival. However, mitotane is not without side effect. It has wide range of adverse effect. Therefore, it is important to limit its use in people with high risk of recurrence. So regarding the European Endocrine Society guideline in this topic, they suggest that adjuvant mitotane treatment in those patients without macroscopic residual tumor after surgery, but who have perceived high risk of recurrence. However, we cannot suggest for it or against adjuvant therapy for a patient at low risk of recurrence. There is a study going on the low-risk group, so hopefully we will have the results available in the next 2-3 years, and we know what exactly should be the recommendations. So if we look at the factors which are, sorry, I think it's not projected on this slide. So the factor which are high risk for recurrence, one is, the most important is the Ki-67, the mitotic rate more than 10 per Hounsfield, the stage 3 disease or stage 3 disease, and also those who have R1 resection. So regarding the Ki-67, it has proven to be one of the best marker in terms of deciding the outcome or the prognosis in patient with adrenocortical cancer after complete resection, which help in deciding either there is a high risk of recurrence or not. So this is a study where they divide the Ki-67 population into 3 groups. So the green one is the one where the tumor Ki-67 is less than 10, the yellow is the one with 10 to 20, and the red is one with more than 20. And the upper one, where the German population, the first one is the recurrence-free survival, and the second one is regarding the overall survival. And you can see that the recurrence as well as the overall survival for patient with less Ki-67 is significantly better as compared to the other. In this study, they compared the German, and they also used the other European patient with ACC for the validation, and the total number is more than 400 in this group, and it's clearly showing that the Ki-67 is a good marker in predicting the outcome. So coming to the adjuvant radiation therapy, the guidelines, the European guidelines on this topic is the panel did not come to a definitive consensus on adjuvant radiation therapy. However, they suggest against the routine use of radiation in low-risk group. The panel suggests considering radiation in addition to mitotane on individualized basis in patient with R1 or RX resection or in stage 3. Regarding the cytotoxic drug, the panel didn't come to the definite consensus on adjuvant use of cytotoxic drug. We suggest against the routine use of cytotoxic drug in adjuvant setting. However, the panel suggests considering adjuvant chemotherapy in selected patients with very high risk of recurrence. Regarding the treatment of advanced ACC, this chart is from European Endocrine Society guidelines. So debulking surgery can be considered in patient where the hormone excess is present, and debulking help in controlling the symptoms. For other patients with advanced disease, the role is mitotane cytotoxic drugs, and the local radiation therapy. And here is the combination that we start with mitotane, and the people who are already taking mitotane, they can be considered for mitotane plus cytotoxic drug, and the local therapies are always the thing which we can use. So regarding our patient, we explored the option of mitotane post-surgically, as the patient had high Ki67 and high mitotic rate. However, mitotane was not available in Pakistan, and also we didn't have mitotane level availability in Pakistan. Our patient had recurrence after 4 months. She had developed pulmonary embolus and pulmonary metastasis. She was referred to palliative care, and she passed away after 6 months. So as you can see, adrenocortical cancer is quite rare, and there is a limited data on the management of prognosis of ACC in developing countries. So we performed a retrospective review of patients with histologically proven ACC that present to Shaukat Khanum Memorial Cancer Hospital between January 2011 to May 2018. We reviewed the clinical features, the treatment outcome, the prognostic factor affecting the survival of patients with ACC, and we have 20 patients were included in this study. What we did, we compared our data to the study which was published in New England Journal in 2007 regarding the use of adjuvant mitotane in adrenocortical cancer. So our population, the median, although it's only 20 patients, but in our group, the median age was 24.5 as compared to the Italian and German group where the median age was 42 to 47. It's more common in females, so 70% of the patients were female. Regarding the clinical feature, so abdominal pain was the most common presenting feature. In female patient, hirsutism, menstrual irregularities was also significantly common. The other non-specific symptoms like headache, weight gain, weight loss was present in a small group, and 3 patients, it was incidental finding where the imaging was done for a completely different reason and adrenal mass was identified. Regarding autonomous adrenal hormone axis, 65% of our patients have autonomous adrenal axis. Glucocorticoid with or without androgen was the main one, and the rest was a small number. And 35% were non-secretory. Hormone was assessed in 17 patients. 3, we were unable to find the record of their hormone results. So 60% of the patients have this lesion on the left side. The mean size of the tumor was 14.61, and modified YC score mean was 5.39. If we go regarding the prognostic factors, we have patient with stage 2 and 3, where 15 was stage 2 and 5 was stage 3. Ki67, we have more patients with Ki67 10 to 20. Mitotic rate less than 10 and more than 10 were roughly about equal, 8 and 10. So in our patients, recurrence developed in 80% of the patient over a median follow-up of 31.75 months. The median recurrence-free survival was 14.5 months, whereas the median overall survival was 24.5. If we compare our median recurrence-free survival with the Italian study, which was Italian and German study, which was published in New England, their recurrence-free survival in people who did not receive the mitotane was 10 months in the Italian group. So this slide actually showed we divide our patients based on the prognostic factor. So the first one is regarding the Ki67. So the one with dark yellow is the one with Ki67 less than 10. The second one, the light yellow, is between 10 to 20, and those who have the Ki-67 more than 20 are in red. So you can see clearly that the recurrence-free survival was significantly different in group with Ki-67 less than 10 as compared to the one where the recurrence-free survival is more than 20. Similarly, for patients with mitotic rate less than 10 and more than 10 is second on the graph, and there was a significant difference. Whereas the third one showing the people, because we have only stage 2 and 3, so stage 2 and stage 3, and you can see in all these prognostic factors, the recurrence-free survival is significantly different in the groups. The same thing for their overall survival, and you can see a difference here, although not much in SNET stage, but Ki-67 and mitotic rate, there was a significant difference in the overall survival. So the challenges in the management of adrenocortical cancer, first is it's quite rare, and as a result, there is a lack of prospective randomized controlled trial. If we talk about the local challenges in developing countries, first is the availability of mitotain. Also, there is no center in Pakistan which do the mitotain level. I don't know about the Sri Lanka or India, but that's also a challenge, because if mitotain level you can't check it, then it's difficult to keep your mitotain level in therapeutic range. And of course, the cost. With this, I will end my talk, and happy to take if there is any questions.